So we're going to get started. If people could take their seats. Realize people are rushing in after lunch. This is a really exciting session for us on cardiovascular disease in women. My name is Leslie Shaw, and I have the privilege of sitting next to the esteemed Erin Mikos from Hopkins, and who has been so supportive of our field and has been such a strong leader, as well as other people in the room. And I think what's really cool about this session is we have so many outstanding leaders in the field of cardiovascular disease here from a lot of different modalities and a lot of different perspectives. So I find the best sessions are those which are the most diverse. And so I think we'll start. And our first speaker, we're so lucky to be able to add Dr. Martha Galati, who's Chief of Cardiology and just overall superstar, and especially in cardiovascular disease in women, who's going to give us the keynote address on sex-based differences in cardiovascular disease implications for imagers. Martha.
Well, thank you for inviting me to give this lecture. And if anybody was in the prevention conference yesterday, I apologize. Some of my jokes are recycled. But for those of you that weren't there, maybe those will be the only people that'll laugh. So I'm going to talk, yesterday I was asked to talk about sort of the prevention arm, but today I'm speaking on the implications for imagers and how the way that at least I work with our cardiovascular imaging folks, specifically related to women, and in ways that I think we can enhance the relationship. So I have no disclosures, but there is differences between men and women. Sex differences do obviously exist. Sometimes things like this, how we see ourselves. Sometimes how we communicate. Apparently when guys say hi, they just mean hi. When women say hi, we mean so much more than hi. But I think George Carlin probably said it best. Here's all you have to know about men and women. Women are crazy and men are stupid, and the main reason women are crazy is because men are stupid. And I'm quoting a man, so nobody, again, can be mad at me. When we talk about cardiovascular disease, though, if you just go to Dr. Google and you ask chest pain, these are the kind of images that come up. They almost always depict a man. And even these Netter diagrams that many of us grew up with during our medical school training, what did we see when they talked about heart disease and how people experienced heart disease? He always depicted a man having a heart attack, as you can see in both of the drawings. If we keep perpetuating that image, we really have a hard time seeing women at risk, which ultimately comes into play in how we take our approaches to treating women. When you put in women's health or at all, you don't see any images of cardiac disease. This is what you see again with Dr. Google. So women's health, they show signs of breast cancer, they show multi-ethnic visions of people with their pink ribbon on, or if they talk about women's health, like I talked about yesterday, it's really bikini-related reproductive systems, so they'll show pregnant women. And not that any of those issues are not important, but it's ignoring the number one killer of women. So of the 1.2 million deaths in the United States of women, over 400,000 of them are due to cardiovascular disease. The next leading cause of death is chronic lung disease. The next leading cause for about 70,000 deaths is lung cancer. And actually the fourth leading cause of death is breast cancer. And yet the press and the way that things are depicted, you would think breast cancer is the leading killer. In terms of prevalence as well, 60 million Americans live with cardiovascular disease compared to 3.5 million women with breast cancer. So in terms of absolute numbers of what we need to be caring about, it's very different. And yet again, the public perception, and even to many physicians and healthcare teams, the perception is that heart disease is a disease of men. Even when we did trials, we ran into trouble because women were often excluded. More recently, in the last few decades, we've been including women in trials, and I think this paper was very telling in terms of adjusting for the prevalence of the disease in women, correcting for the prevalence, actually. You can see we've made some headway, particularly in atrial fibrillation, hypertension, and pulmonary hypertension. We're getting a fair representation of women based on the prevalence. If anything, in pulmonary hypertension, we've overrepresented women, which would be the first time. But in common diseases like coronary artery disease, acute coronary syndrome, and heart failure, we still have an underrepresentation of women in the most common forms of cardiovascular disease. Yet for imagers, when they are looking at differences, we actually find very useful information. This is just one example of a study where they did stratify by sex, and they showed that, in fact, perfusion and function were important prognostic indicators for both men and women, but actually perfusion added even more information to predicting adverse cardiovascular events in women, and that's in the top graph compared to men on the lower side, that if you had perfusion abnormality as well as a low ejection fraction, you had worse outcomes, and it was worse for women. So when we talk about sex and gender, it's not that they're actually interchanged. I mean, sex is biological. Gender is a socially construed concept, as I talked about yesterday, and all of these matter when we're talking about any form of cardiovascular disease in terms of how they're treated and how they're diagnosed. There's certain gender influences like access to care, employment, cost of drugs, etc., where people live, but the biological influence of sex is also important. And all of these are things that we should be taking into consideration when we're treating women, when we're diagnosing women, and ultimately trying to improve their outcomes. So how does sex actually impact guideline-directed care? Well, we have a lot of evidence. I could have chose any of the number of studies across the world that all continue to show the same thing. This is from the United States, the Get With The Guideline data that shows after a myocardial infarction, we treat women less effectively than men. You can see that the odds of a woman getting treatment, early treatment, aspirin or beta blocker, is less compared with men after a myocardial infarction. Women are less likely to be offered an invasive procedure, and they're less likely to achieve door-to-balloon times and door-to-needle times that are within the acceptable limits. The only thing women do better than men is die, and particularly the ST elevation myocardial infarction group is the one that remains statistically significant. That was older data from 2008, but we continue to follow this data, and we continue to see the same patterns. In 2016, we looked at it again, and they still showed women had higher death rates and also more bleeding, and that it was worse to be a woman, but it was worse to be a Black woman. VIRGO trial was specifically a study that was looking at young women with ST elevation myocardial infarction, and although there was no difference in the endpoint in this study based on delays in care, you could see that women were less likely to get aggressive care. You can just see here for door-to-balloon time, it was 8 minutes longer when they were in the hospital. They still achieved the 90-minute threshold for the majority of them, but if they were transferred to the hospital, it was 30 minutes longer for a woman compared to a man, and exceeding the 120 minutes that's acceptable for out-of-hospital transfers. And we know that younger women specifically do the worst of any group, so these delays in care can actually translate into worse outcomes outside of the VIRGO trial where they were at very good hospitals. The other thing that we see in women after myocardial infarction is that women, the youngest women, are more likely to be re-hospitalized. You can see that the younger ones are the solid lines, and black is for men and gray is for women. And you can see very quickly in that first year after a myocardial infarction that these lines separate. It's also true that when you're over the age of 55, too, women as well still have greater rehospitalization, but it's probably the most dramatic for the youngest women. Perhaps because of these delays in care, perhaps also due to lack of aggressive or guideline-recommended therapies, and then referrals to cardiac rehab, that all may be influencing outcomes. There's other things that can affect how we care for women in terms of how we diagnose women. We know there's a term that was coined by Dr. Bernadine Healy called Yentl Syndrome. For those of you that know the story of Yentl or the movie about Yentl, it's also a story as well. Played by Barbara Streisand, Yentl disguised herself as a man in order to be taken seriously. She wanted to study the Talmud, and the only way she could was to disguise herself as a man. The idea that Dr. Bernadine Healy was putting forth that only if women present exactly like men do they get taken seriously, and maybe that's the reason that women were being less aggressively cared for. Additionally, we use terms like the word atypical, and it is true that women may have different patterns of chest pain or how they present, but the word atypical in the medical community has suddenly been translated, rather than being a less typical version of this disease, it's become code for it's not heart disease. We're not going to do any additional testing. So again, regardless of how women describe their symptoms, we know women have more symptoms than men. And it is true, though, that women have less obstructive coronary disease regardless of symptoms. And so these are sex differences that we care about, that we need to know more about. Again, from the VIRGO trial, we see that women are treated differently. But it's the first time that we were able to look at younger women to see if there was differences in their presentation and in their symptoms. And actually 90% of young women and men, and these are again under the age of 55, presented with chest pain, chest pressure, tightness, or discomfort. So they actually did have the symptoms. Maybe it's how we're asking the question is why we don't, or how we're listening to their responses, that we're not hearing their symptoms. But women were actually more likely to respond saying that they had 3 or more other symptoms along with that chest discomfort. So compared to men who were less likely to report other symptoms. Now, when women actually sought out care, they were told that their symptoms were less likely to be heart-related. And these are people that all went on, obviously, to have an ST elevation myocardial infarction. Here's when they were asked, what did they think their symptoms were due to, women were more likely to think it was stress and anxiety. So we've convinced them well that this is not their heart. Men were more likely to think it was muscle pain. And then their decision about why they sought medical care is eventually men thought it could be a heart problem, more likely than women. And women were more worried about other health problems, which is why they sought out care. Additionally, though, that translated into delays in care. Women were more likely to seek out emergency room visit more than 6 hours later. And in terms of a physician response, many of them, almost a third of women, actually sought medical care before their actual ST elevation myocardial infarction. And more often they were told that this is not cardiac compared to men. You can see 53% compared to 36%. And so again, there's a difference in the medical approach of how we see women when they're presenting with these symptoms. So the other question you have to ask, and you're going to hear about this a little bit more, is whether the guidelines even apply to women. And I know that Dr. Shah, I believe, is going to be talking more about this. And my only point from this slide, because she'll go into the detail about this, is we have these guidelines about stable ischemic heart disease. And what do they focus on when you look at this flow chart? It's almost exclusively saying, is there an obstructive lesion? That has been our overt focus, that when you're symptomatic, can we find this critical stenosis? And even many of us trained, and we saw this diagram shown to us repeatedly, saying that the only way that you could have an abnormal stress test or symptoms was to have an obstructive lesion. And yet we know now in this modern age that that is just not true. We know this actually even from a not-so-modern age. From the Gusto trial, we saw whether you had a STEMI, a non-STEMI, or unstable angina, men and women were both often met the criteria for this, but did not have an obstructive lesion, particularly in unstable angina, and obviously more frequently in women, where they didn't find an obstructive lesion, where they were quote-unquote normal coronary arteries. Nobody really questioned that. I mean, these were true findings, but never really moved past the idea that somehow we were still searching for an obstructive lesion. Dr. Shaw has presented this work where the ACC registry, the cath-PCI registry, looking at both stable ischemic heart disease and acute coronary syndrome, showing that again, for men and women, but more commonly in women, across all races, there was more likely to have a non-obstructive lesion. And a non-obstructive lesion was here, under 70% stenosis. And yet women, compared to men, were more likely to have adverse outcomes despite this fact that they had less obstructive lesions. We also showed using the WISE data, the Women Ischemic Syndrome Evaluation study. They were women that had to have signs and symptoms of ischemia, and we compared them to a normal cohort known as the Women Take Heart cohort, and you can see them shown in these graphs stratified by risk factors, that again, even the most interesting group I found was the people without any obstructive lesions, 0% stenosis by cath, still went on to have more cardiovascular events, but because they had signs of ischemia and symptoms of ischemia. So their symptoms did matter, and the fact that tests detected ischemia did matter. So there is somewhat of a paradigm shift now where imaging really comes into play. This idea that you had to have an obstructive lesion is really moving away. Really, it's because we focused exclusively on this, and pathological studies even, they were also looking for the obstructive lesion. And ultimately, this got reinforced in all of our literature to basically convince people when you had evidence of ischemia, but you didn't find an obstructive lesion, those were quote-unquote false positives. And maybe their symptoms were atypical and somehow had less meaning, even though to the person experiencing them, they were meaningful. And so now we talk about different forms of diseases. Of course, the obstructive lesions are important, but now we talk about ANOCA, ischemia with no obstructive coronary arteries, and if they have a myocardial infarction, MINOCA, or a myocardial infarction with no obstructive coronary artery disease. And you'll hear, again, more about this shortly, but my only point about ANOCA, the ischemia with no obstructive coronary arteries, is it's more common than you think. And this is where the role of imaging really matters. We need to figure out what tests to use to diagnose this, how best to interpret it. Of course, potential treatments, we're not there yet. There are huge knowledge gaps for us in this group, but the fact that we really only started studying women in the last decade or two, and additionally, we've just started getting results of trials, really makes this the area that we need answers for in the future. So I think there's a lot more work to do. We have these guidelines that many of you probably are familiar with, the diagnostic evaluation for women with suspected ischemic heart disease. And I had the honor of being part of these with Dr. Meares and Dr. Shaw. And here, what we were even suggesting at that time, that we knew that women specifically did not have always obstructive disease, but there was a role for other testing that needed to take place, even if you believed their symptoms and if you had evidence of ischemia, that you didn't just stop after whether you decided about doing a cath or not. And that's essentially our practice had really been looking at an obstructive lesion and then looking for it and then stopping. Now, there's many things that come into play for radiologists and cardiovascular imagers related to radiation exposure, and I think this is very important in our women patients. And so it's important to consider any type of testing that we're doing in women, and cumulative testing too. Sometimes we're doing over-testing in these women, and just making sure we choose the right tests and know what amount of radiation we're exposing women to. And additionally, there is strategies that your labs can take to try to minimize radiation in women. And again, these are things that I know many people in this audience, I don't have to necessarily educate them about. Now, in terms of, again, the patterns of coronary disease, we like the obstructive coronary disease because we're really essentially cardiologists or plumbers, and, we can open them up. We know what to do with that. But the problem is if it's microvascular, if it's endothelial dysfunction, if it's positive remodeling, we still need to know what to do with them and what kind of medical management would improve this. So this is the area that I think we all need to be focusing on for the future. And again, we have this working model for the pathophysiology. I don't know if we know all the answers to this, but the point being that you don't need an obstructive lesion. That might be along the pathway, but you can have what looks like a normal coronary artery, but abnormal microvascular function or abnormal endothelial dysfunction because of the stressors and the inflammation and some of the unique things specific to women that are potentially affecting their vascular response. And we know that through the lifetime of a woman, there are things that are different between women compared to men. Some of them hormone related, sometimes it's things as a gender that you're exposed to that might influence your cardiovascular disease and vascular response. And there's a lot more about the biology of sex that we still are determining in terms of even the regulatory system and organ function that we really need to know more about. So I guess when the next time somebody says to you that this stress test was abnormal but they had no obstructive lesion and someone labels it as a false positive, I guess either you need to replace your imager because you have bad imaging techniques, and I don't know why you believe any of your imaging, because that really to me is the main issue. It either is true or it's not true. But if it's true ischemia, it doesn't have to be obstructive coronary disease. And I think this is where we need to move to when we're talking about ischemia. I don't even like anymore the word coronary artery disease because somehow it implies to our community an obstructive lesion rather than ischemic heart disease. So that's just my personal belief. Now in terms of the things we can do, and I'm taking this from Dr. Tenkedi, who is presenting some point after me, in terms of imaging for women, I think there's a lot of things that we need to do. Of course, we need more trials of women, including women, but I think the imaging community has been better at that than most. We need to, of course, select appropriate women and appropriate testing, the radiation reduction as I talked about, and leverage our technology for the right tests for women, and be really the gatekeepers for imaging for women, and figuring out what we are trying to answer, what we're trying to diagnose. The one unique thing about imaging is not always is this the case, but sometimes the imager is blind. They don't know whether it's male or female. Right? So sometimes that's to their favor that we're not introducing the bias that we introduce every day when we look at women, because we know there is a bias in how we treat women. So maybe this is a unique opportunity where the imager looks at everyone the same. So my conclusion is just women with cardiovascular disease, as I told you, they receive less aggressive care and they do have worse outcomes, particularly the younger women. And ischemic heart disease is a major threat to women across their lifetime. And we really need to know how to use our imaging tools to optimize the diagnosis of ischemic heart disease in women, but also minimize or limit radiation. And I think that there's really strong data for CCTA and for myocardial perfusion imaging in women that is quite robust and really helps us accurately detect the presence or absence of obstructive coronary disease, but even non-obstructive coronary disease, and helps us with risk stratification and appropriate utilization of downstream procedures. And I think the integration of both function and anatomy really will help us, particularly in the stable ischemic heart disease women, and provide management guidance for women and men with ANOCA. And I do think we have a lot more work to do, and of course, women are more complicated. They should have started studying us first, but now we'll play catch up. So thank you.
Great. Thank you, Dr. Galati, for that excellent talk. We'll save questions and things, I think, for at the end during our panel session. So now it's my great pleasure to introduce my fellow co-chair, Dr. Leslie Shaw, who is a true thought leader when it comes to this field about imaging in women. She's quite accomplished with more than 600 publications and has been past president of both the American Society of Nuclear Cardiology and the past president of the Society of Cardiac Computed Tomography. So for a woman to be a president of a society and to be past president of two societies is quite impressive. And so I'm really looking forward to her talk, Contemporary Studies and Guidelines that have redefined our understanding of atherosclerosis in women.
Thank you, Dr. Mikos. Thank you, Dr. Galati, for a superb presentation, and you've segued a lot and can really help me a lot in my presentation. If you're like me, every person that talks, it kind of sinks in a little bit more, a little bit more, a little bit more, and so I'm hoping some of Dr. Galati will segue into some of the things I have to say. Martha covered very nicely the difference between sex and gender. I think it's extremely important for you to think about this and mull this in your head if you're developing women's clinics or whatever, because many of the factors related to the social roles of women influence what we do every day. It influences healthcare access, it influences referral patterns, and as Martha very nicely says, it influences our guidelines or our policy implications and just how our healthcare system is developed, designed, and how it's actually practiced. And that as disproportionately disadvantages women for a lot of reasons, whether it be financial, whether it be just the social milieu. I'm going to focus on the biology, but we cannot disentangle sex from gender, even though we do talk about sex differences. They very much impact outcomes. So, and most of what I will talk about. Martha nicely talked about this, and I was involved in writing the sections on diagnostic testing for this guideline in 2012. And the goal of the diagnostic testing algorithms are to identify folks that then will benefit from referral to the cath lab, i.e. the detection of obstructive coronary disease. And as Martha nicely talked about, and here's just 3 illustrative examples, women have less obstructive disease. That doesn't mean that the symptoms are not real. It doesn't mean that the symptoms are not associated with any form of atherosclerosis. But what we find is that women might not have the extent and the severity of obstructive coronary disease, but they have a huge burden of atherosclerosis. If you look at PROMISE, 2/3 of the women had atherosclerosis. Many of your patient populations may not have obstructive disease, but they have atherosclerosis. Here's just a paper that I was involved with Mike Blaha, one of Aaron's colleagues from the Calcium Consortium. This, as you can see, it's a very large cohort of almost 67,000 patients that underwent coronary calcium scoring. If you look at the populations in that middle age group, at least half of the women are going to have some form of calcified plaque, and somewhere after the age of 45, when you get that natural loss or declining in endogenous estrogen, the average age of menopause is 51 years, somewhere around that. Some of your patients who are obese, some of your patients who are HIV positive, some of your patients who are diabetic are going to go through menopause early. An HIV positive woman could go through menopause on average a decade before that. So you have to think about the onset of menopause in these patient populations. That's where you're going to see the prevalence increase in your population. And very nicely, both Martha and I are on the ACC's Cardiovascular Disease in Women Committee. We published this very, very nice review paper that Dr. Carl Pepin, who has spent his entire career focusing on non-obstructive disease in women. You can't read that, so don't worry. I'm going to make it bigger for you. It's important for you to realize that the prevalence of coronary disease, prevalence of non-obstructive coronary disease is much greater in women. I personally believe in the last 5 years or so of my research career has focused on developing a specific phenotype that we can say is specific for women in terms of this non-obstructive disease phenotype. And what I think is important for us to also realize is that there potentially could be a different etiology for acute coronary syndromes in women. There's this higher prevalence of plaque erosion as compared to acute coronary thrombosis. thrombosis or thrombus formation with subsequent thrombus formation and plaque erosion versus plaque rupture. And there are often multiple mechanisms, which Viviani's going to talk about. I'm going to try to stay way away from Viviani because she's the expert in this, and we're really privileged to have her. What is interesting is that despite having less obstructive disease, many times women have a higher risk. So here's just 3 nice examples from the CONFIRM registry. Everybody knows this in this room. You could close your eyes, and if I could tell you, tell me 2 papers that you know showing non-obstructive disease on CT is associated with worsening outcomes. You probably, for many of you, these would be these 2 papers, both of which I am a co-author on. So the first paper just showed that in a large cohort of about 23,000 patients, non-obstructive disease was associated with a worsening outcome. Now, if many of the people in the room are not as old as I am, but many times we used to lump normal coronaries and non-obstructive disease together and just say, oh, you know, that's nothing. That's nothing, as Martha talked about. Now we're beginning to see that, and I even hate to say it in front of this audience, is that plaque is bad. Oh, there's a big light bulb that went off in our head, right? I mean, we should have been thinking that all along, and we should get our hands slapped for not thinking that. But here we see some nice examples and a growing body of evidence that the presence of any atherosclerotic plaque is not normal, absent no stenosis, no plaque, very low risk, and associated with worsening outcome. What's fundamental to your understanding about this phenotype of non-obstructive disease is that here you see a luminogram with invasive coronary angiography. This is where it's very hard for the interventionalist. It's a luminogram. But when you start to look more deeply, whether using CT or invasive approaches like here intravascular ultrasound, you see that if you don't have an obstructive lesion, about 80%, and maybe this is off a little bit, but this is from the WISE. I was a WISE investigator, maybe not WISE investigator, but a women's ischemia syndrome investigator. About 80% of the women in WISE that had a non-obstructive disease, 80% of them have atherosclerotic plaque. So what can we do? We struggle at times with knowing what to do with women. If you know they have atherosclerosis, all the preventive cardiologists in the room know what to do about that. So that's the point that we need to have taken. And what's really fascinating is that I told you that a lot of my career, at least in the last 5 years, has been developing this sex-specific phenotype on atherosclerosis in women. What we see interesting, and this is a pattern, this is again from my EHJ paper, is if you look at detective coronary calcium, just the presence of calcified plaque, is that women have roughly a 30% higher mortality if they have detectable plaque versus those that do, versus their male counterparts. So this is fascinating. Just the presence of plaque alone is going to increase risk in women more so than men. And if you look not just from the Calcium Consortium with Mike Blaha leads, but here's some data from MESA, also published in European Heart Journal in 2018. You show a nice ability to risk stratify in the MESA for women and men based upon this coronary calcium score. Simple, easy, $50 test looking at detection of calcified plaque can nicely identify those at risk, including women and men. And we once again I've struggled with coming up with this concept of this sex-specific phenotype or this sex-specific signature, but the whole idea is that we do know that women more often have plaque erosion, this kind of specific morphology with they have pathologic intimal thickening or fibroatheroma, and this occurs in autopsy in about 40% of sudden cardiac death cases. It's more common in women. Is this the source, perhaps the pathobiologic source, for a different sex-specific signature? We do know what we see, more non-occlusive disease, less plaque burden, more eccentric lesions, and frequently not calcified. Is this what we're seeing? Is this spec-specific phenotype that would love to find? It's still elusive to me, but I want you to keep it in the back of your mind that we do have kind of pieces of information that there is this unique specific signature in women. Here's data from the PROMISE trial from Maris Ferenczak, published in JAMA Cardiology at the end of last year. Really super amazing a study that looked at high-risk plaque features. Those of you who are not familiar with the high-risk plaque features, low attenuation or this dark plaque,
on CT, positive remodeling, that expansive remodeling, or this napkin ring sign, which just is a rim of dark surrounded by a lighter part of plaque. And you can see these three features, the presence of any of those three features were associated with an elevated risk and promise, just over 2 years of follow-up. That's amazing in this patient population. And what was even more amazing from this paper, what Marish published, is that the features, these high-risk plaque features, were more predictive in women than men. Should I say it again? Seriously, though, guys, I mean, this is something that's really important for us to identify, these sex-specific signatures that we have here. We're starting to get these pieces to put together this puzzle that we could actually justify developing unique strategies and understanding risk. I also think that there's this very fascinating relationship about stenosis and ischemia. Now, all of you were taught about demand ischemia, right? This is like ingrained in your head. You, at some point, you have an obstructive lesion, it's going to be ischemic. Well, what we are seeing is that about half the time you could have a stenosis, and about half the time it could be ischemic, half the time not. Well, for a lot of reasons, right? For a lot of reasons, collateral flow, et cetera. But what's interesting is somewhere in the neighborhood of 20 to 30% of non-obstructive lesions are ischemic. Not false positives, as Martha said. They truly are ischemic. Okay, so where can we go from here? And I think the world, and this is where I'm trying to be a little bit argumentative with Viviani, my good friend Viviani, who I think is amazing, is that the world has focused on this, Anoka, in terms of understanding ischemia in the setting of non-obstructive disease. I'm going to challenge you a little bit and focus you on a trial that we just finished called Credence, where we actually looked at CT plaque predictors of ischemia, plaque predictors of ischemia, or lumen predictors, I should put it this way. And those of you interventionalists in the room will see, I'm going to just go right to the punchline. Now look at the major predictors of ischemia, FFR, invasive FFR ischemia, major predictors from Credence. The stenosis severity, so that supports your idea of demand ischemia. Non-calcified plaque volume. This has been shown now in about 6 studies. That fatty plaque is more associated with ischemia, and now again in Credence. The number of mild lesions, so the cumulative burden of these milder lesions in terms of downstream impact in terms of ischemia. Oh, but wait, now, so that's non-obstructive disease. So now I can tell you with CT, you can actually identify ischemic lesions just by knowing there's serial lesions or there's a bifurcation with a couple lesions. But now look at this predictor, lumen volume. A smaller lumen volume, not necessarily having any plaque, just having a smaller vessel is associated. Now, the interventionalists have known this for years, but now all of a sudden we can say a small lumen volume, and particularly I would love to know some tending perhaps an excessive LV mass or subtending a larger myocardial mass. That can be true ischemia. So now we're getting you to think differently about ischemia. We're looking at the lumen, we're looking at plaque, we're giving you alternative explanations that can actually start to guide you in terms of understanding, as well as these high-risk plaque features here. So now we've come full circle in a totally different perspective on how we define ischemia. We can define ischemia not just by looking at flow, not just by looking at perfusion. Now we can look at it in terms of understanding the plaque characteristics. So I'm just going to finish this up by telling you that I've had this great opportunity to think very broadly and very uniquely about ischemic heart disease in women. I think plaque is extremely important for to understand a woman's prognosis and anybody's prognosis. And I think the non-obstructive disease is a key to understanding risk. It is a huge key for us to unlock in understanding risk. These vessel-specific measures that we talked about, I think, could be vastly important to the CT community for us to understand a patient's symptoms, and particularly for us to understand the symptoms, cardiac symptoms in women, the persistent symptoms in women that make them come back and back and back to the emergency room despite being not labeled as having coronary disease. So thank you very much.
That was excellent. So as Dr. Shaw is taking her seat, I'll have the pleasure of introducing our next speaker, Dr. Viviane Tacchetti from Brigham and Women's Hospital. You've already heard about her work alluded to by the first two speakers, so it's a real pleasure to have her here to talk about her own work with us. And she's going to be speaking on microvascular dysfunction, when to suspect and how to evaluate.
Thank you both very much. It's really an honor to be here. And I'm actually going to pick up right where Drs. Galati and Dr. Shaw left off to pose to you that perhaps because they were designed for identification of obstructive CAD, conventional approaches to diagnostic testing in stable ischemic heart disease can lead to over-testing without actually differentiating who's truly at risk. And that may be because obstructive coronary artery disease involving the epicardial arteries, as you've already heard, really represents but one phenotype of ischemic heart disease and does not necessarily take into account the microcirculation. And yet we know that in patients with refractory angina, despite non-obstructive coronary artery disease, or even patients who had prior history of obstructive disease that has been already optimally revascularized, coronary microvascular dysfunction may be the culprit. We can try to measure coronary microvascular dysfunction by assessing a measure called coronary flow reserve, which we can actually get at with several different modalities, including both non-invasive as well as invasive approaches. And I will focus on positron emission tomography, which is one of the most validated non-invasive approaches. And you can see that with essentially 2 10-minute scans, you can capture a lot of information, including from the static pictures, the perfusion, or a global assessment of LV percent ischemia. From the ECG-gated images, you can look at the ejection fraction. And then, importantly, from the dynamic images, you can actually quantify absolute blood flow in mils per minute per gram of LV mass, or LV tissue. And you can measure those values at rest as well as at stress and average those over the entire left ventricle to come up with that ratio of stress over rest blood flows that is known as the coronary flow reserve. And here you can see data from our group as well as multiple other centers showing that coronary flow reserve values, as they go down, risk of cardiac mortality goes up. And you can see that if patients can at least double their blood flows from rest to stress and have a flow reserve value of above 2, that portends a much better prognosis than those who can't. And that may be from a combination, actually, of obstructive disease, diffuse atherosclerosis, or microvascular dysfunction. We and others have shown that this is independent of obstructive coronary artery disease. In the circle in the red, you can see these are patients who had essentially less than 50% stenosis on coronary angiography and had a very wide range of flow reserve values, including very low flow reserves. And those patients who had impaired flow reserves with or without obstructive disease had much worse prognosis. We know that coronary flow reserve also interacts with positive troponin to modify risk in patients who otherwise have pretty low risk. So these are patients who underwent PET stress testing for evaluation of symptoms and were found to have completely normal perfusion, normal ejection fractions, but a subset of them had a detectable troponin in very small quantities. And you can see that it was only the patients with the positive troponins as well as the impaired flow reserves who actually had much worse risk. And furthermore, impaired flow reserve in these patients with normal perfusion can also interact with diastolic dysfunction, as we can measure on echocardiography, to modify risk, particularly of future heart failure with preserved ejection fraction presentations. Coronary flow reserve helps to reclassify risk in diabetic patients, those with metabolic syndrome. It's associated with worsening body mass index, and perhaps it will allow us to better phenotype patients in terms of risk. So how prevalent is it? And so these are data showing that in patients who presented, again, with symptoms of chest pain or dyspnea and underwent PET stress testing, about 50% of them actually had flow reserve values that were less than 2. So these were patients, again, who on traditional stress testing had normal perfusion, normal ejection fractions, would essentially be considered normal stress tests. And you can see that for both men and women, about half of them had impaired flow reserves. And those patients with flow reserves less than 2 also had much worse prognosis. And to Leslie's point, this was true even for those subset of patients, around 200 of the 1,200, who had calcium scores of 0. And yet, when severely impaired, flow reserves are even more prognostically significant in women. I showed you that for a borderline flow reserve of around 2, both men and women have worse prognosis, and there's no difference between sexes. But as you get lower and lower into the flow reserve values, here you can see towards flow reserve values of 1.6 or 1.5, you start to see a difference in risk, such that both men and women are at risk, but the women are at even greater risk. And we don't fully know why that is, but what's interesting about these patients, if you take that group of patients who have severely impaired flow reserves or 1.6 or below, most of the men have obstructive CAD or single vessel or obstructive, but most of the women have either single vessel or non-obstructive disease, and this corroborates with decades of data where symptomatic women who are referred for invasive angiography will very frequently demonstrate non-obstructive disease. And so it's still possible to have non-obstructive disease on invasive angiography and have very impaired flow reserves, perhaps as the etiology for the symptoms that patients are presenting with. So I wanted to essentially go through 2 cases illustrating the extremes of how flow reserves may be helpful to differentiate and diagnose coronary microvascular dysfunction. So the first is of a 67-year-old woman with obesity and diabetes, hypertension, who had a history of coronary artery disease for which she had undergone an RCA PCI 3 years before, and she'd actually been presenting with recurrent exertional anginal symptoms and dyspnea. She couldn't walk upstairs anymore, which was new for her, without having chest pain, which was fairly typical in its presentation. It was improved by rest on sublingual nitroglycerin and had been worse over the preceding few weeks. She was on a good medical regimen on aspirin, rosuvastatin, clopidogrel, antihypertensive insulin. Her ECG didn't show anything, any acute ST segment abnormalities. She'd had an echocardiogram which showed mild LVH with preserved ejection fraction, as well as grade 2 diastolic dysfunction. And she'd had one of several vasodilator SPECT studies, this one most recently 2 weeks before presentation, which was had actually shown normal myocardial perfusion imaging and a normal ejection fraction. So her clinicians were concerned enough about her symptoms that they went ahead and did an invasive coronary angiogram. And what you can see is that it's not completely normal. However, there are epicardial coronary arteries are patent, and there are no flow-limiting stenoses. There's a mid-RCA lesion, which was FFR'd with a value that was non-flow-limiting at 0.88, and there are other areas of plaque and mild luminal narrowing. You can see the ostial RCA in one of the branch marginals, for example. So she subsequently underwent a cardiac PET stress test, and what you can see is that she had significant evidence of ischemia on the stress images on the top, followed by the rest images below. So it was characterized as a medium-sized perfusion defect in the stress images, mostly along the apical inferior and mid-septal segments, with some TID in that region, but fairly subtle. And yet her flow reserves were not subtle, so you can maybe make out, but it's quite small, that she had abnormal regional and global rest and stress flows. So her stress, total stress flows was 1.11, normal being 1.8 or above. Her rest flows were 0.8, which is pretty typical, and therefore her reserve value was only 1.4, so in the severely impaired category. So in the end, you have a patient who had prior PCI, continued to have no new flow-limiting stenoses explaining her symptoms, but had significant ischemia and particularly very severely impaired flow reserve values. So this is a case that a colleague of mine, Alex Schmeyer, talented fellow at Brigham and Women's, published together in Circulation. And I invite you to take a look because we go through her presentation, her management, and what can we do for management in these patients, which is somewhat outside the scope of my talk today. Case 2 sounds similar in that it was a 63-year-old woman with hypertension and positive family history for early coronary artery disease who also came in with recurrent chest pain. This time, this patient described it as more typical when she became upset and with stress, to Dr. Gulati's point from the VIRGO data. Her ECG also did not show any acute ST segment abnormalities, and in the past, she'd actually had recently undergone an exercise treadmill test for which she exercised quite well at 11 METs, stopped for fatigue and no ischemic changes. And her clinician went ahead and ordered a calcium score, which showed a calcium score of 256, putting her in the 95th percentile, so quite severe for her age and sex range, with mostly concentrated calcium along the LAD at 272. They went on, actually, despite that, to get a coronary CTA, which showed a moderate stenosis in the mid-LAD, which was described as a CAD-RADS 3, possibly but not definitely hemodynamically significant. So they went ahead and did a stress PET study in this patient, and her perfusion images looked normal, except for a basal ammonia lateral artifact. And her PET flow reserve values actually were quite normal, very much in the normal range, with stress flows in the 2.4 range globally and leading to reserve flows of 2.8. So well above 2, and in this patient, much more likely to portend with a very good prognosis despite her calcium score. And so she was initiated on an aspirin, low-dose aspirin, and a atorvastatin 40. And in fact, her symptoms were reported to have resolved in subsequent follow-up, and she stopped getting repeated stress testing. So this is a summary slide of the extended algorithm for all of us to consider as we think about diagnosis and diagnostic testing strategies in patients with suspected ischemic heart disease. And the main takeaway from this slide is to say whether you start with a functional or an anatomic strategy, unexplained symptoms in patients do merit consideration of testing for coronary microvascular dysfunction. So we no longer stop at a cath that shows a non-obstructive disease, and we don't necessarily even stop at normal perfusion testing, but of course have to consider the patient's presentation and possibility for undiagnosed disease. So finally, the takeaway points that I'll leave you with today is that the focus we've had in the past on obstructive CAD and heart failure with reduced ejection fraction is no longer adequate. Moving forward, effective diagnostic testing, I would posit, needs to identify patients who are at high risk of events, not just anatomically obstructive CAD per se, but without over-testing those who are at low risk, and this may involve diagnostic testing for microvascular dysfunction. And finally, ultimately, to get somewhere where we can talk about guidelines and management, the characterization of the underlying pathophysiology is necessary so that we can better diagnose disease, define prognosis, and ultimately tailor new management strategies to individual patients. So with that, I will leave you and thank all of my colleagues in the cardiovascular imaging program at Brigham and Women's Hospital, Dr. Ron Blankstein for putting together a fantastic meeting so far, and Dr. Leslie Shaw for all of your support, and I think you're an honorary member of our group. So thank you very much.
Speaker, thank you. There's Quinn. I got a little nervous, Quinn. I didn't see you back there. So we're going to introduce Dr. Quinn Trong, who is one of my colleagues from Cornell. She's going to talk about the unique role of cardiac CT in evaluating women with suspected coronary disease. Quinn.
Thank you, Dr. Shaw. Okay, so this is my talk on unique role of cardiac CT in evaluating women with suspected coronary artery disease. Here are my disclosures. So what's the clinical equipoise in women in cardiac CT? Coronary artery disease is a leading cause of mortality in women in the United States. There's higher rates of false positive stress testing, there's nonspecific ST wave abnormalities, and there's breast attenuation on nuclear scan. So then there may be a role for cardiac CTA in women, and what exactly is that role? So I want to go through a couple trials in the acute chest pain as well as in the stable chest pain randomized trials that had sub-analysis for women. So in ROMICAT-2, which is the rule-out myocardial infarction by computer-assisted tomography trial that enrolled 1,000 patients, 224 women in the CCTA arm, and their endpoint was length of stay. What we find here is when you look at the proportion of patients that were discharged, because remember the endpoint was length of stay, and the hour and the length of stay here is on hours on the x-axis. What we find is right here in the solid red is the CCTA woman arm, and women benefited most from early CCTAs compared to men. So ROMICAT-2 was randomizing CCTA versus standard of care, all standard of care testing, including stress, ETT, nuclear, stress echo, etc. And then the sex difference was also adjusted for mean and median length of stay and persisted after adjustment for all risk factors that were different, including ACS rate. So then we decided to look at to see, well, maybe women are being treated differently in the ED population from men. So we decided to see what if both men and women had normal CCTA. Were they treated differently? Well, the answer is no. They were treated identical. So in the setting of normal CCTA, both women and men were able to be discharged from the ED expeditiously most of them within 6 hours. So then we wanted to see, well, what's the meaning behind this, and how does this work in terms of CT versus the standard testing? So here, if you look at the CCTA arm, what you can see is that women had more normal CTs than men, 58% versus 37%. While if you look at the standard evaluation with the various stress tests, the normal C rates of women and men were comparable. So in summary of this slide is women have more normal CCTA than men, while in terms of stress testing, they were equal. So in looking, with CT and categories of stenosis, here we have the CAD-RADS. The CAD-RADS severity is there's no disease, minimal, mild disease, moderate disease, severe is greater than 70, and total occlusion. And that's kind of how we grade CTAs. So what CT can also offer, though, is that it can detect non-calcified plaque right here. So this would have been missed on a calcium score right here. And this is the unique aspect of CCTA over calcium score and over any other stress testing, because we can actually see both stenosis and morphology and plaque morphology. Here's the high-grade stenosis in the mid-RCA. Moving along to another trial, this is in the stable chest pain cohort, PROMISE Prospective Multicenter Imaging Study for Evaluation of Chest Pain. And this is, again, a randomized trial in the stable chest pain cohort instead of the acute chest pain cohort. And they randomized over close to 9,000 patients to CT arm first or standard of care first. And their outcome is MACE. I think they went out to 3 years. And what we can look here is, when you look here at these values, women were less likely to have a positive CCTA than stress tests. So it's actually 8 versus 12%. So women were less likely to have a positive CCTA than stress tests. So how do these positive tests relate to clinical events? So we look only in the women's subgroup right here. You can see that women in CCTA arm, those with positive CCTA were more likely to have events than those in the stress test. So this is normal in the blue, abnormal in the red. So about close to 6-fold increase if you had an abnormal CCTA for MACE versus about 2-fold for a stress test. So women with positive CCTA were more likely to have an event than those with a positive stress test, and the p-value for that is significant. So let's see how CCTA compared to each individual stress test. Right here, you can see the overall is that CCTA was less likely to be positive. So women were less likely to have positive CCTA than positive stress tests. Additionally, what we see here in this graph is that CCTA was less likely positive than stress nuclear and ETT, but not stress echo. So what's the downstream effect at 1 year? So Crescent, which is another multi-center trial where they use a calcium score evaluation and selective CT angiography strategy first and compared to functional testing for suspected CAD. So it enrolled about 350 patients of stable chest pain. 192 of them were female, and they did a subgroup analysis of females at 1 year. What they found at 1 year was that the anginal-free symptoms were about 40% in the CCTA arm for women versus 22% in the functional arm. Okay? And they also found that women in the CCTA arm had less testing. They only had 16% downstream testing, 16% versus 57%. Okay? If you were in the CT arm, you had less testing at 1 year than if you were in the stress test arm. And this is also, there's a P interaction, so there was a sex difference between men versus women. Now, what about the impact of non-obstructive disease? Now, I have shown you the categories for stenosis that we grade. So obviously, moderate stenosis, severe and occluded versus no disease are actually, well, easy. I think Leslie had alluded to, the importance of non-obstructive coronary disease. So that actually falls into this minimal stenosis or mild stenosis. So from 1 to 49% right here, minimal and then mild disease. What is that impact for women? So when you look at the confirmed registry, this one is, they had over 5,000 patients, 36% were female, and they followed patients out for 5 years. What they found was, for MACE, patients with non-obstructive disease had about 2-fold in women and 2.5-fold increase risk of MACE than those who did not have any disease. So both men and women had a 2-fold increased risk for MACE, for 5-year MACE, as compared to those who had no disease. So what about non-obstructive disease? Non-obstructive left main disease, right here. So confirm also then look to see what's the impact of non-obstructive left main disease on 5-year MACE. So again, over 5,000 patients, 925 had non-obstructive left main, 29% were female, 5-year follow-up for mortality. And what's interesting here is obviously, this is we expect this. If you have non-obstructive left main, you're likely going to have more MACE than if you had no disease. But what's important, but what's important is when you look at the subgroup analysis, women who had non-obstructive left main disease had 28% MACE versus 10% here, and then men was only 14 and 10%, okay? So basically what it says is women with non-obstructive disease, non-obstructive left main, had the worst prognosis over men even. So the P interaction, that was very significant. So women with non-obstructive disease of the left main fared worse than men with non-obstructive disease. Now, I can't talk about women and CCTA without talking about radiation dose, because everyone's like, So So let's break it down by test type, okay? So yes, it is true, CCTA uses radiation. So when we looked at, this is back in 2013 when we did the ROMI-CAT2 sub-analysis, is nuclear stress test was about 14, 15 millisieverts in men and in women, while a CCTA was a little bit less for women, about 9 to 11 millisieverts, and men was around that much too, okay? So still pretty high, but what I want to point out to you is back then we had a sub-analysis, small group, just 29 patients in our cohort, where they had it in the dual source scanner, and they were about like 5 millisieverts, okay? So radiation, there is radiation concern, but it's much lower in women, especially when it's used with the newer scanner. So more contemporary analysis with the Protection 2 and the Protection 6 trial that was just published this past in 2018, if you look at the radiation dose between women and men, just overall, women had an overall 2 millisievert versus men was 2.6 millisieverts for radiation dose exposure from a single CCTA, okay? This is really important. We were talking about 5 years ago when we were about like 10, 11 millisieverts. Now on average, okay, on average, we're about 2 millisieverts. Okay. Some of the things that we may find with when we're looking for suspected coronary disease, some of the unique aspect of CCTA is sometimes we find stuff like this. Really annoys me because I don't want to find this. I want to find coronary disease or I want to find clean disease, but sometimes we see stuff like this. But this is actually life-saving when we do see this. This is here is an aortic dissection. Okay? We also sometimes find this. I hate finding this, but I do find it, This is a pulmonary embolism. Not what we want to see, but when you see it, it's very life-changing, right? And this is a unique aspect that you're not going to find with nuclear or other stress testing or other imaging modality. What about this? Yes, this is even worse. This is what I hate the most, I think, over the other two, is this pulmonary mass right here. Life-changing for the patient, right? But this is what we can find on CT also. And lastly, I wanted to show you, not life-saving or life-changing, but in the setting of no disease or non-obstructive disease, sometimes we find something like this. Right here, these little small things here. I love calling it, my radiologist colleague says ignore it, but I call it because you know what, we have no other reason. This is a small hiatal hernia. This can be the reason why your patients are having symptoms. And this, you may be able to see large hiatal hernia on a nuclear scan, you're not going to be able to find the small one. So this is another benefit of having a CCTA scan. So in conclusion, women benefit from CCTA due to the high normalcy rate and thus fewer one-year downstream testing. Women with non-obstructive disease have higher MACE than those who had no CAD, especially those with non-obstructive left main. Contemporary CT radiation exposure is low, lowest in women. And also CCTA offers alternative diagnosis and additional incidental findings that even though we're not looking for it, really can change a patient's life. Thank you.
And I'd like to introduce our next speaker, who truly is an icon when we think about women's cardiovascular health. And this is Dr. Melissa Wood, who is the director of the Corrigan Heart Health Program at Massachusetts General Hospital, who's going to be talking to us about an area she has a lot of expertise in, which is coronary dissection, spontaneous coronary dissection. How do we diagnose and how to manage?
Thank you very much to the chairs, Dr. Shaw and Dr. Mikos, and also to the chair of this program, Dr. Blankstein. It's really a pleasure to be here, and thank you for including a lowly echocardiographer amidst your esteemed crowd. So in the next few minutes, I'm going to talk about coronary artery dissection, and I think for those of you in the audience that are in the field of the industry and developing new technology, I think we've heard through the past few speakers who've been fabulous that there's need for better technology to better understand the complex coronary anatomy and physiology of women. And I think that my talk will add to the head scratching on ways that we can improve imaging to have better outcomes in women, with cardiovascular disease still being the #1 killer. So I thought this is actually someone else's disclosure slide. Okay, so Could I have my, oh, sorry.
Yeah,
Thanks.
let's just click on your name.
Yep. I'm like, I don't work for SIHD. I have no disclosures. So with that, we'll move on. I guess click the mouse. Great. Ah. Okay. All right. So coronary dissection. So I wanted to start with a case. This is a 28-year-old female who presented with chest pain 14 days after the birth of a 6-pound, 4-ounce baby girl. She presented and knew that her symptoms were something that she'd never felt before, so immediately sought care and was found to have anterolateral ST elevation, had positive troponin. An ECG done immediately in the an echo in the emergency room revealed a clear Walmshut abnormality. So she did not, they did not wait. They took her straight to the cath lab. And as you can see, and this is an example of multi-vessel severe coronary artery dissection with disease involving most of the major coronary tree vessels. And that's really typical for what we see with some of these peripartum cases. Again, extensive dissection involving the LAD, the left circumflex. And as they continued to take pictures, and this reminds me of that saying, better is the enemy of good. When you have what you need, you do not need to keep injecting dye. So they kept injecting dye, and unfortunately she had a profound progression of her dissections and developed occlusion that went all the way back up to the left main. She, however, was managed absolutely perfectly by the acute shock team. She was placed on ECMO and was managed conservatively. Cardiac surgeons did consult, but they knew the data that suggested that she would heal if she could be managed, and she stabilized very quickly. Therefore, they were able to manage her conservatively. She improved, as I said, quickly. Her EF went from 20% to 55% in hospital, and she was discharged home. She underwent the typical screening that we now offer patients after dissection, even those who have peripartum dissection, and did not have evidence of FMD. She successfully completed cardiac rehab and still comes to see me with her baby and now young toddler in follow-up. So in the next few minutes, I wanted to talk a bit about coronary dissection, which I'm sure most of you are quite familiar with now. But I still think it's very important to remember some of the key take-home points, especially for those of you who are going to be looking at imaging in patients coming through the emergency room with chest pain. I want to tell you a little bit about the epidemiology of SCAD. What does the usual patient look like? Discuss the 3 types, and as you will see, interestingly, there is some overlap between what we might call non-calcified plaque and what may be one unusual form of dissection. They may look very similar on CT and cath imaging, and then talk about some of the conditions associated with SCAD that require additional imaging and evaluation, and briefly touch on the role of CT in this condition and the management. So with regard to the definition of SCAD, really we talk about it as being a dissection or interruption in the normal wall of a blood vessel that is not due to an iatrogenic cause, atherosclerosis, or any type of mechanical trauma. And Dr. David Adlam and his colleagues have described it very eloquently as the inside-out hypothesis, which is when you have a tear or disruption in the intima and hematoma spreads into the media of the vessel, versus the, that's the inside out, and then the outside in is the second type, where you have development of hematoma or sometimes edema within the wall of the vessel, within the media, and that compresses the lumen of the blood vessel. This is a cross-sectional area rendering of the different types, the 2 major types of SCAD. So the type 1, which is the inside out, where you have the tear of the wall, and the type 2, where you have the accumulation of either edema or blood within the wall of the vessel, and then there's a histopathologic sample. And interestingly, I can tell you, I guess it's in a way good that Dr. Renu Vermani, who's really the world's expert on coronary pathology, has less than 50 samples of coronaries affected by SCAD. Now that tells us that the people who ended up in her lab obviously didn't do well, but also that they were pretty obvious cases that led to identification. So I think we need to do a lot more to better understand the physiology and what happens in the vessel. I was fortunate enough to be part of a writing group that wrote the scientific statement that really summarized what we know to date about coronary dissection, and I'll review some of the key take-home points from that paper that was published in Circ last year. So essentially, SCAD probably, and I will say at least, because I think it's still grossly underdiagnosed, it's responsible for at least 1 to 4% of ACS overall, at least 1/3, if not more, of MI in women under 50. We think it's actually far more than that. 43% of all pregnancy-associated heart attacks, and most of the women who present with SCAD have few traditional risk factors. This is a figure from Dr. Jackie Saw's data. She has the largest series to date, which is multi-site, prospective/retrospective from Canada, beautiful series of over 700 patients. In her series, the mean age is 52.5 and largely female. This is a summary of her series, 88.5% women, mean age 52. The second largest series is the Mayo Clinic, Dr. Sharon Hayes, Dr. Marisa Tweet, who really put this condition on the map. They also have largely a female population. At MGH, our series, we have a bit more of a male mix, but still it's largely women. About 30% present with STEMI, much more common in your peripartum cases, 70% non-STEMI. And when you do screening, at least in Dr. Saw's series, only about a third had FMD, and you'll see data from Mayo and from our group, it's a little bit higher. Two key take-home messages from Dr. Saw's work, really these are important. First is the peripartum patients have the highest major in-hospital worsened outcomes, with 20% MACE versus 8.2% of those who are non-peripartum. And then two groups have worsened 30-day MACE, and that's pregnancy and those with connective tissue disorders. As with other conditions, the main presenting symptom is really chest pain, but you can see the panoply of other symptoms that these patients may present with, and these are, again, typically young, otherwise healthy patients. So it's so important that people understand when they feel something they haven't felt before that they seek medical assistance. So we think about I think about the two buckets in which SCAD occurs. One is triggers or events that happen in time. The other is conditions that lead to vascular vulnerability. Some of those triggers or precipitating events include those that are associated with a surge of adrenaline. And that leads to increased heart rate, increased blood pressure, sheer stress. And that can be either something like an acute emotional stressor or vigorous physical activity. Also, things such as cocaine use or energy drinks have been associated with acute SCAD. Also, hormone exposure, such as acute hormone exposure, both in men and women with both testosterone as well as estrogen. Conditions that are associated with vascular vulnerability certainly include pregnancy and the postpartum state. The initial, recognition of SCAD, because the pregnant woman with an MI, it was such an obvious type of MI, we really initially thought that was almost half of SCAD. Now we realize that the pregnancy-associated SCADs are far less common than we thought in the beginning and make up really only about 12% total of our patients. There are vascular conditions that are associated but not causally related to SCAD, and those include FMD or fibromuscular dysplasia, as well as the genetically mediated vasculopathies such as vascular EDS, Marfan, Louis-Dietz, and then less likely rheumatologic disorders like SLE, PAN, or hypereosinophilia. This is an example of a type 2 dissection involving the mid to distal LAD. Now, the three types of SCAD that exist, or that we have come up with nomenclature so far for, include the type 1, which is again the intimal tear, classically associated with a dye stain. So it actually looks very similar to the type of dissection we see when we've done a procedure, so an iatrogenic dissection. So we've really damaged the wall, and there's dye staining when the dye washes out. Then there's the type 2, which is the more common form, and that is where you have compression of the lumen. And I love that Dr. Shaw used my favorite term as well, which is luminogram, and I was an interventionalist for a while, and I remember how many times we'd see caths that would look pretty normal, and yet the patient had positive enzymes. And I think now we recognize that there are so many shortcomings with cardiac catheterization because all we're seeing is the lumen of the vessel. In type 2 dissections, you can see that lumen is constricted. A type 2A dissection involves the middle part of the vessel but does not extend all the way to the tip, and a type 2B does go all the way to the tip of the vessel, and that actually is important when we think about the type of intervention that we want to do if an intervention is indicated. Finally, there's the type 3, and these are our head scratchers. These are the ones that can certainly be confused, I think, with non-calcified plaque because they're short, very focal, but they are usually symmetric and smooth. And really the only way to identify this is with an intracoronary imaging such as OCT or IVUS. This is another example of that compression of the lumen and then seeing how that compression can change over time. So when we think about diagnosis of SCAD, I think we need to have heightened suspicion in young, otherwise healthy, I would say men and women, but most commonly women. And I think, sort of in the ER now, we've gotten much better at recognizing that young men and women can have acute coronary syndromes for a variety of reasons. So certainly checking with that troponin, especially now with the HS-TNT, getting a bedside echo, looking for a wall motion abnormality. Remember, great way to identify whether or not there's actually single coronary or multiple vessels involved. And then doing the ECG. And we would recommend proceeding to cath if the patient has ongoing symptoms unrelieved with nitroglycerin, ST elevation, or hemodynamic instability. Now, going on to cath is associated with risk because we do recognize that there's an increased risk of iatrogenic dissection in patients who have coronary artery dissections. And also we know that the success rate of PCI is far lower in SCAD than it is in other forms, but when we really need to have a diagnosis, I think we need to go straight to cath. I will mention that when you do cath, we still should go through the femoral because there's an increased risk of iatrogenic dissection from the radial approach in patients who have coronary artery dissections. And then IVUS and OCT are very helpful in the cath lab, especially if one is uncertain about whether or not you're dealing with a type 3 versus plaque disruption. I will say, however, in our laboratory where we have some very experienced operators at MGH, our team does not like to put a wire down a vessel unless they plan to put a stent there because they know that the risk of placing a wire into the false lumen is significant and can cause abrupt closure of a vessel. So we really are not doing that, although in the literature you'll see it, it's robustly reported. Now the role for CT in clinically stable patients I think is there, and we'll talk about that a little bit, and certainly CTA is very helpful in demonstrating resolution. Now, this is some info about sort of comparing CT to cath, and Dr. Brian Goshadra in the audience has shared some of his slides with me that I will show you. Certainly for now, I think gold standard remains the key for coronary angiography. Again, it's a luminogram. It doesn't tell us what's going on in the wall, but it is the way to get that diagnosis, especially because right now we recognize that patients can have fairly severe symptoms, even cardiac arrest, and yet only have dissection involving the tip of a small vessel. I've seen patients present with cardiac arrest, and about 10% of SCAD patients present with cardiac arrest in just a small distal OM or a distal PLV. It's also really tough sometimes on CT to differentiate distal pruning that we normally see, especially in sick patients who are in shock, from a type 2 dissection. It's also difficult to separate or differentiate non-calcified plaque from those type 3s, as I mentioned. And, sometimes it's really hard to, if we don't have disruption of the wall of the vessel, to see contrast. However, again, I think it may be very helpful in the non-invasive follow-up and in the assessment of clinically stable patients. Now, an example of how difficult it actually is to identify SCAD would be this angiogram, because I think you can see here, if I can get it to play again, let's see if we can get this big guy to play. All right, okay, so I'll go back to the prior slide and see if we can get that to play. Okay, well, this is the next one. The first one, it was very hard to pick up the SCAD. On this one, you can see in this image of the same patient, there is in fact a type 1 SCAD involving an OM, but I can't tell you how many angiograms I ever viewed of patients who had their caths done elsewhere where they were told they just had coronary vasospasm or in fact completely normal coronaries, because many angiographers are looking for that focal tight lesion consistent with atherosclerosis. They're not looking for tubular changes or sort of abrupt changes in the appearance of a coronary artery. Now, this is a slide borrowed from Dr. Goshadra, who's in our audience, really comparing CCTA to invasive coronary angiography, sort of showing some of the limitations of CCTA, which include spatial and temporal resolution, as you can see here. And looking, the spatial resolution of CCTA, at least at this point in this type of imaging, is 0.4 to 0.6 versus 0.16 in coronary angiography that's invasive, and the temporal resolution certainly is much better. However, the densities that are seen, the contrast resolution, as you can tell here, is superior in CCTA. And again, I want to thank Dr. Goshadra, and if you don't know, you should follow him on Twitter because he's Brian with the good dictations at Goshadra. And I cannot tell you how valuable Brian is as a member of our SCAD team at MGH. He is always available to review films from outside and certainly is very involved in patients coming from the emergency room or that we are caring for. This is another case that he shared with us. It shows the value of CCTA in the emergency room. This was a young woman who had developed chest pain after receiving a breakup text from a naughty boy, and she was having chest pain. And actually, I think maybe had a triple rule out because I think there was a concern for her also having an aortic dissection. So they did cores and aorta, but her aorta, in fact, her coronaries did reveal this long lesion, and she did go on to coronary angiography and was found to have this type 2 dissection involving the mid-LAD. No text is worth a life. This is an example of using CCTA to follow up a patient where there was a distal type 2 dissection in the LAD, and then showing that there was persistent dissection, but that in fact it looked like it perhaps had improved maybe a tad, but not much, but it was still persistent. We are not recommending follow-up imaging in patients unless they're having new symptoms or persistent symptoms, because really the majority of these patients heal completely if left alone, and usually their symptoms improve relatively quickly. This is an example of OCT, panel A, and in panel B, IVUS. Now the OCT shows an intimal dissection, type A, and then our type 1, and then panel B shows a type 2 or intramural hematoma. And again, very helpful when done, but must be done by your A team with experience. Now this is an unusual case because this patient actually had 2 follow-up caths because of ongoing symptoms. And you can really see the stark, or the degree to which the vessels were diffusely decreased in caliber and sort of gradual improvement over the next 2 weeks on their subsequent angiography. Now, I'd also like to share some new data from our group. I noticed when I started looking at these angiograms about a decade ago that oftentimes this type 2 dissection seemed to occur at that hinge point between a hyperdynamic base and akinesis, or the mid-vessel. And there's almost a 90-degree angle with that bend in the vessel at that site. And so we went back and looked retrospectively and then had another group blindly look at our angiograms. And in those cases of SCAD who had a left ventriculogram, 58% of them had ventriculograms that actually were very consistent with Takotsubo. Now, the way that we separated that from patients who had LAD disease, number one, we looked for patients who had perfusion. So they had TIMI 2 or greater flow into the LAD, and they had on ventriculography a hyperdynamic base and that classic sort of apical and mid-ventricular hypokinesis to dyskinesis consistent with Takotsubo. And we thought about this because it is very interesting that in both cases, many of the patients present with sudden onset of chest pain in the setting of emotional stress. And here's an example of a patient from our series who merely had an OM dissection and yet had hyperdynamic base and apical dyskinesis, demonstrating that occurrence of that bend in the vessel at the site of her Takotsubo. And I think if we went back to Brian's image, one would also notice that there was a hyperdynamic sort of basal function here, kind of that was at that same level of the abnormality in the vessel. So one thing that we also use CT for regularly is following up our patients. We do CTA head, neck, abdomen, and pelvis to look for fibromuscular dysplasia. They seem to go hand in hand. We don't think the FMD causes the SCAD, certainly, but when we look for it, we see it. In the Vancouver series from Canada, 50% of SCAD patients had some form of FMD. In the Mayo series, which is more in line with what we see at MGH, Many of the patients have vascular abnormalities, and we call it arteriopathy. When we classically look for the beating, that is less common, maybe in our series 40 to 50%, but overall vascular abnormalities with dissections, aneurysms, tortuosity, and undulating aorta can be seen in up to 2/3 of or 3/4 of the patients. And Mayo found the same thing. It is very important to do this, and I can tell you I had to fight with insurance companies with those peer-to-peer prior authorizations to get these scans done. But in fact, if a patient has FMD or other disease, they're likely about 10% of them may have an intracranial aneurysm, and that's very important to know about. Finally, looking at the genetics of these patients has been found to be relatively low yield if they don't have an obvious family history or exam. In our series, 8% had positive genetics. If we look at other factors in addition to pregnancy, we can see again the systemic inflammatory conditions are also relatively rare. Now, just a plug for when patients in the peripartum suite or the postpartum suite have chest pain, it's important to evaluate them. Again, most common cause of MI is SCAD. It usually occurs immediately after delivery or in the first 4 to 5 weeks after, and it is associated with a higher risk of cardiogenic shock, death, and cardiovascular compromise and long-term LV dysfunction. So these patients need to be managed carefully. Medical management is the mainstay of therapy. We know that these patients improve if left alone. There are no guidelines. Our paper was a scientific statement that sort of summarized the recommendation. When you see SCAD, you should stop heparin, and that is very, very different from our traditional ACS algorithm. This is a case of a young woman that I manage who presented with chest pain. She has Ehlers-Danlos, had known Ehlers-Danlos, presented with chest pain, was in another state. This is her immediate cath done right after she presented. She had clear dissection involving multiple vessels, and this is the cath after heparin was started. Literally an hour after the heparin was started, she had progressive severe obstruction of multiple vessels. She's doing well to date, but has persistent LV dysfunction. So to summarize medical therapy, ACE and ARB only if needed for LV dysfunction or hypertension. Beta blockers and aspirin are really the only therapies that we continue long-term in these patients. There's no indication for therapy unless they would meet it otherwise. Beta blockers, however, do appear to prevent recurrence. This is in retrospective data, and prospective studies are being done. If you go ahead and do PCI, it should be individuals who have 0 to 1 TIMI flow or hemodynamic compromise. If it's a long lesion, you want to stent the proximal and distal segments before you stent the middle. Otherwise, you're going to be chasing that hematoma as it expands. I did say it to avoid radial access. If you can figure that out in advance, that it's likely to be SCAD. Dr. Saw has used cutting balloons, as have a big group in Japan, to fenestrate the wall of these vessels. Our team, they're afraid to put wires down the vessels. They certainly don't want to use a cutting balloon in a fragile vessel, but there are some interesting case reports. Recovery is very important because these young, healthy patients are left with a lot of questions and a great deal of anxiety, so we really need to send them to cardiac rehab, and I'm leading a peer mentoring training program for young women who've had MI from all forms, but in particular, especially SCAD. We do have specific recommendations. Most of our patients are very athletic prior, and so we want to get them back to exercise, but we do have some of the limitations as listed here. We are part of the iSCAD registry, which is now up to updated number 17 sites around the US. Talk to me if you're interested in participating. It's an investigator-led initiative that we'll be doing. And finally, in closure, think about SCAD, again, in young patients with symptoms. You want to look for evidence of ischemia and then decide whether you want to do a CT or cath first. We still have a lot we need to learn about why this happens, how we can potentially prevent it, and how we can better treat it. And cardiac rehab remains safe and is associated with improved outcomes. And certainly CT is a large part of of our care team for these patients. And I want to thank all my colleagues who really are part of the village that it takes to care for SCAD patients. Email or follow me on Twitter if you have any questions. Thanks.
Dr. Wood, wow, that was I could have listened for another hour. It was amazing, quite amazing. So our last speaker, and then we get to some discussion, is some case presentations by Dr. Sarah Reinhardt from Atlanta.
Thank you for the opportunity to speak today. I tried to present a case that wasn't covered in today's topics, and I have no relevant disclosures. So my case is a 46-year-old African-American female who has a history of hypertension. She presents to the hospital in significant volume overload and shortness of breath. She was in acute kidney failure and had a significant pulmonary embolus as well. She was treated with anticoagulation, and given her acute kidney injury, she was actually placed on hemodialysis. During her kidney evaluation, she was found to have stage 4 lupus nephritis. So if we're looking at this patient, she already has 2 significant risk factors for females, including both hypertension and lupus. So her initial echocardiogram was very abnormal with an LVEF of 35 to 40%, and she had valvular disease and also evidence of mild pulmonary hypertension. The volume was removed by hemodialysis, and she was placed on goal-directed medical therapy for her heart failure. And she was later diagnosed with antiphospholipid antibody syndrome and was placed on warfarin. So in follow-up, we were looking at other preventive things that we could do for her, and her cholesterol was found to be 305 with an LDL of 234. So again, now she has a familial form of hypercholesterolemia in addition to her other 2 risk factors. So while we can see Framingham may not be applicable to her, and we know that Framingham risk scores underestimate disease in women less than 70, and actually 84% of women with significant calcium, greater than the 75th percentile, are actually classified as low Framingham risk. So in 2011, Dr. Wanger and a group looked at different risk models for women, and I want to highlight the at-risk category. So in addition to the standard risk factors, they also include metabolic syndrome, polycystic ovarian syndrome, poor exercise capacity, autoimmune disease, including lupus and rheumatoid arthritis, but also pregnancy-induced hypertension and preeclampsia. So again, this patient had lupus. So when I'm seeing this patient in clinic, I look at the population-based guidelines, but you also want to look at the female independent risk factors and also look at the individual. And she was considered at risk. She had hypertension, familial hypercholesterolemia, as well as lupus. So we did a calcium score on her, and this was in 2010, and it was 0. We still placed her on Crestor therapy because of her at-risk conditions. So in follow-up, she was treated for her lupus. She was no longer on dialysis. Her kidney function returned to normal. Her LVEF is slowly improving. Her lipids improved as well on Crestor 20. Her LDL went from 234 down to 114. So she was lost to follow-up. She's one of these patients who travels from Atlanta to Tennessee for her job, and she came back because she was having palpitations. And again, she'd stopped her Coreg and her statin, and we resumed both of those at her office visit. And again, her cholesterol is now significantly elevated. Her EKG demonstrated just nonspecific ST segment changes. So at the same time, we're looking at some of the data and looking at what we can do to improve risk prediction in our female population as part of our Women's Heart Program. And again, when we're looking at breast cancer, that's the major concern for a lot of women, but we know it only affects 1 in 7 women, whereas heart disease affects 1 in 3 women. So we also know that a lot of our younger females may not see a primary care physician, they may not see or have their lipids drawn, but they may get their mammogram when they turn 40, because a lot of these patients still just see their OB gynecologist. So breast arterial calcification is traditionally in literature found to be in 10 to 12% of patients. And even with this conservative measure, we could identify breast arterial calcification in the United States in 2 to 3 million women. So the question is, how can we take this information and be helpful? So this study in 2007 actually demonstrated that a calcium score was positive in about 53% of the women who had breast arterial calcification. And again, the interesting thing, it's a different pathophysiology between coronary artery disease and people with breast arterial calcification. One particularly interesting thing is smoking does not seem to influence breast arterial calcification, but it may be more the number of children you have, if you've breastfed your children, or been on oral contraceptives. This study really helped influence what we chose to do with our program. This study actually found back in 42% of women who had the digital mammogram. And what they found actually was a statistical analysis for people with positive coronary artery calcium scores with BAC was that the positive predictive value was actually 70%. And I really like Dr. Nasir's editorial on this because this basically means that 70% of these women could be reclassified as high-risk patients. And the presence could be at least comparable to potentially diabetes. We also know that as the breast arterial calcification density and presence increases, so does the coronary artery calcification. And also, it's very additive to the standard cardiovascular risk factors. Now, the Scott Hart sub-study didn't demonstrate as dramatic an effect, and this table actually illustrates that there is a lot of variability in the research because the specificity ranged from 12 to 97%, and the positive predictive value of breast arterial calcification to coronary artery calcification ranged from 23 to 95%. But despite that variability, what we can identify is that breast arterial calcification can be considered a red flag for coronary artery disease. So as part of the Women's Consensus document, we actually put out a summary statement that women with breast arterial calcification may benefit from calcium score scanning for further risk detection and to help guide prevention care decision making. So what we did at our institution is we met with the Breast Imaging Council, which includes our radiologists, mammographers, surgeons, oncologists, and we worked together to form a committee to actually put a statement out on every mammogram report that has breast arterial calcification. And basically it states that the presence of BAC should actually prompt a patient-doctor discussion for whether cardiovascular risk evaluation is needed. So as we go back to our patient, she was lost to follow-up, but she had her mammogram, and she now has breast arterial calcification on her mammogram, and she was like, Dr. Reinhardt, what does this mean? So we did another calcium score. This is 8 years later. Remember, she had hypertension, familial hypercholesterolemia, and lupus. Now her calcium score went from 0 to 60, and she's at the 92nd percentile. So this is a key opportunity for all of us to have a huge impact on patients who may not seek preventive care, but may seek mammograms and actually how we can influence cardiovascular disease at a much earlier stage in life. So this is one of my patients' thoughts I wanted to give to you.
Take a minute, schedule it, put it on the calendar. Us women, we take care of everybody else. We put ourselves last. And it's so important that we actually take a minute to take care of ourselves.
So I think this is a great conclusion to the session where we can really impact our female patients' lives. Thank you.
I think that's a great place to stop with that patient has the last word. All of the talks were phenomenal. Viviani, Melissa, amazing, just amazing. I could have sat here all day, honestly. Thank you very much for everybody attending.